Today's lecture is going to be on suicide. The importance of suicide relates to the fact that there are 32,000 people who have completed acts of suicide every year. On average, one person in every 16 minutes. People over the age of 65, especially white men over 85, have the highest rate for any U.S. group. A lot of times this is related to loss of relationships, chronic illness, social isolation, and economic issues. Suicide is the third leading cause for young people, related to decision making, decreased life experience, risk taking, and substance abuse. 90% of suicides are associated with mental illness or alcohol and substance abuse. Teen suicide, nearly 5 times as common amongst boys and girls. Males are more likely to use guns. Women try twice as often as men, and a lot of suicides are as a result of unwitnessed death. So you may have instances where it appears to be a hunting accident or an auto accident, when in actuality it was a suicide attempt. These are just some other statistics as far as the epidemiology of suicide and self-harm. With suicide, the biggest thing that I want you to take from this slide is the fact that suicide has a tendency to run in families. So who's most likely to engage in self-harm? You have individuals who have diminished intellectual capacity, so they either have poor judgment, lack the ability to have coping skills, or are targets of abuse. They can be patients with psychosis that have command hallucinations or delusions. Some of them can come from the prison population. Others may have personality disorders, borderline personality disorders, mood disorders, PTSD, and as I mentioned in the earlier statistics, just being an older adult, especially over the age of 85. Many of these individuals are at risk, more so, especially or if they exhibit some of these characteristics that you see below, which include hostility, impulsivity, depression, hopelessness, social withdrawal, low self-esteem, not having really trust of others, being rigid and inflexible in their ways of thinking, or if they have experienced divorce, guilt, or loss. So some type of relationship or disability. 90% of individuals who complete suicide have attached with that a psychiatric illness. As we talked about before, mood disorders, but in addition, it can be substance abuse, schizophrenia, anxiety disorders. Many people who die from suicide have a prior history of an attempt, and that makes them a higher risk. They may have a family history of suicide. They could have physical or chronically or terminal illness. So if they have a diagnosis like cancer, then you may see individuals who attempt to commit suicide. Psychosocially stressed, that feeling of low self-worth, they have this feeling that, like that things aren't going to be able to change. They don't feel like they can make it better. They begin to feel useless. And so it's a struggle with this population. I see it every day. One of the biggest things that I can say is the importance of why, as nurses, we have this obligation to instill within our patients hope that their life can change, that things can become better. So what are we going to do and what are we not going to do? Behaviors that we're going to be looking for. A lot of the times, non-compliance is at the top of the list. They're non-compliant to the treatment plan. Self-injury, just remembering that that's a deliberate act to harm themselves, and they don't need anyone else to help them with it. It's not really an attempt to end their life, but it's the intent is to make their injury severe enough to cause some type of tissue damage. So they'll use cutting and burning skin, banging their heads and limbs, picking at wounds, chewing fingers. However, there are often times when, due to lack of knowledge, the death is accidental because the cut is too deep and it nicks an artery. With suicidal behaviors, remember that all behaviors are serious, whatever the intent, and deserves our highest priority. When it comes to suicidal ideations, thought of self-inflicted death, self-reported, or reported to others. So you may have a patient who comes in and have had these thoughts, or someone is coming to you reporting this information to you. Sometimes patients will say things that they have passive thoughts. So they only have thoughts of suicide, no plan. But with active, they actually have a plan of how they're going to end their lives. With suicide threats, they can be verbal or nonverbal warnings. They can be direct or indirect, as how they're going to, or in the ways in which they're going to take their own life. Regardless, these are some of the things that we just have to take into consideration. At any given time, a person's passive thoughts can turn to active, and so therefore we're constantly doing that assessment and asking those difficult questions. We're also going to assess for social isolation. Are they crying, have poor concentration, disinterested in pleasurable experiences, or if they have expressions of anxiety? Some things you want to think about is, how would you specifically assess someone for social isolation? How would a client display disinterest in life? How long have the symptoms lasted? And how might a client express these anxieties? We're going to be looking for gestures of signs that they may be thinking about suicide, such as saying goodbye, putting their affairs in order, giving away possessions, having this appearance of being at peace or happy. They may convey social messages and death wishes. But what is the appropriate intervention for a client suspected of displaying suicidal behaviors? The biggest thing is just to simply ask if they're having thoughts to want to harm themselves or others. Other assessment tools, we can use the SAD person scale that uses 10 major risk factors to assess for the potential for suicide. We're going to be looking at what their sex is, how old are they, do they have depression, have they had a previous attempt, are they using or abusing substances including alcohol. What about their support system? Do they have that? Is there an organized plan? Do they not have family or spouses? And if so, how recent was a loss of a spouse? Or is there a sickness, acute or chronic? So when we're thinking about, again, the importance of suicide assessment, it goes back to what I said earlier, is assessing the patient by asking them, do they have a plan or means to carry out that plan? Assessing for what their behavior is. Is there a lethality to that method that they're going to choose? A lot of times, again, individuals who have the potential for suicide can use highly lethal methods like a gunshot to the head. Some of them has specific plans, such as when my spouse leaves to go shopping. The means, again, can be a loaded gun in a desk drawer. It can be a bottle of pills they've been saving up. When it comes to these plans really have to be taken seriously. When an individual is truly intent upon taking their lives, they become concentrated in creating a well thought out plan. They're not ambivalent about dying. So this really becomes serious. So, does the person seem ambivalent? Could the person be using the threat as a means of asking for help? More than not. If they are telling us, it is them crying out for help. When an individual's self-esteem or self-worth isn't as high as it could be, and or is very low, then they can begin to exhibit self-destructive behaviors. And at this point, it is highly suspectable that suicide is a thought that they're going to have, or that they're going to start to exhibit behaviors related to having suicidal ideations. Other things that we can look at when it comes to risk factors for suicide behavior is looking at a Beck's depression inventory, or again, really just doing your very thorough assessment and asking those questions. When doing your suicidal assessment, ask direct questions about their thoughts and plans. In order to ask those questions, you really have to have a good nurse-patient relationship. You have to establish an emotional connection with that individual. Give the client or your patient the opportunity to discuss their feelings. A lot of the times when they're openly talking about it, they don't want to carry it out. They just feel that they have to, and they need someone to stop them. And it brings them relief if you can just ask them about it. A lot of the times, if you can engage them in conversation, they might abandon their thoughts to want to commit suicide, if not for that moment, during their admission. And that's just because all they need is to feel that someone in their life cares. Emotional ties with others also are keys to suicide prevention. What are the expected outcomes? Well, the biggest outcome that you're going to have is that your client's not going to physically harm him or herself. So you're going to create short-term goals, that the client will not harm himself or herself while being hospitalized, that they'll sign a safety contract or renew agreements to comply daily. So are they daily contracting for safety? And in some facilities, they'll allow them to do it verbally. Usually on admission, they sign a written contract for safety, and then daily they have to commit to a verbal compliance to this contract. Another outcome could be that the client begins to self-reflect and identify causes and triggers of these suicidal ideations. Other long-term goals can be that the client will recognize and seek help when experiencing suicidal ideations. When it comes to your client not acting on suicidal impulses, short-term goals can include that the client will not act upon suicidal impulses while hospitalized, that they will identify coping mechanisms to deal with these impulses, that they will show the ability to implement new coping mechanisms, and that they'll identify resources to contact when they're having suicidal ideations. Your long-term goal will be that the client will not act upon suicidal impulses, but rather contact support resources and institute effective coping mechanisms. Our ultimate goal is to have the preservation of life. That's our highest priority. Maslow says that safety of all our patients is important. So as nurses, we have to help the client to control their impulses by emphasizing several thoughts. Understanding that when they're in crisis, that it's immediate. And helping them understand that the trigger for these impulses will pass. Then we're going to manage their plan for emotional pain. And this is going to be ongoing. So they might need grief therapy. Then we're going to help them find available resources. They're going to need this. This is going to be ongoing throughout their lifetime. And so we have to make sure that also for them to want to continue using resources, that they trust us. The only way they're going to trust us is through that nurse-client relationship. They're also going to need the assistance of a psychotherapist. Helping them understand that they are not alone. This is going to be immediate, especially during that crisis, but also ongoing, that you are not by yourself. And even though sometimes when we feel it in this world that no one else understands what we're going through and that we're alone in our own thoughts and our feelings, or literally alone because we don't have family, that our family can extend outside of ourselves into our friendships. And so therefore, we're going to help them with family, friend, and support groups. And remembering that, again, the key to preventing a patient from committing suicide is that emotional connection that they create with others. And then tell them that as nurses, our goal is to do everything that's possible to keep them from hurting themselves. So what do I do if they're suicidal? What interventions? We're going to closely monitor them. So if you have a patient that's admitted because they have suicidal ideations, we're going to get them the contract for safety. Then we're going to put suicide precautions in. So they're going to be checking on them every 15 minutes to ensure their safety, and in documenting that. We're going to be checking to see whether or not it's just ideations and no plan. And usually when we're doing the 15-minute checks, those are for patients who have ideations but have no plan. And then we're going to be using medication therapy with them. Ask the patient to stay in a common area or to be so that they can be closely observed. And then again, most units we're doing that 15-minute check. With our patients who are suicidal, other interventions that we can do include contracting with that suicidal client. So we're going to contract with them by having a discussion and having the patient agree to not engaging in self-harm for a certain period of time. So for example, we're going to say for the next 12 hours, or for the duration of your hospital stay, or for 1 month, usually it's 24 hours during the hospitalization time, that the patient will not. And then finish your statement and your documentation. Other ways that we can get them to contract for safety is to have them to be willing to contact someone if they have thoughts of self-destructive behavior. And say, I'm going to be, and how that works a lot of times is me just saying, good morning, my name is Lisa, I'm going to be a nurse today. I noticed that as part of your mission that you admitted for suicidal ideations. Are you still having any thoughts to want to harm yourself? They'll say yes or no. Then I'll say, do you have thoughts that you want to harm someone else? They'll say yes or no. And then I'll say, well, part of our arrangement here at whatever facility is that our patients contract for safety. What that means is that right now you don't have any thoughts or plans to want to harm yourself. However, should that change, should you begin to have thoughts that become overwhelming and you feel like you need to engage in self-harm, that you'll come and get me. Can you do that? If the patient tells me yes, then I'll let them know that I'm going to continue to check on them every 15 minutes, or that the aide will check on them every 15 minutes. And if they say no, they can't contract for safety, then I contact another nurse. I stay with the patient at the time, and I tell them, can you get the doctor? The patient can't contract for safety, and now they need to be on a one-to-one, which is a person who sits with their patient all the time in constant visual to be there to protect them from themselves. Closely monitoring suicidal patients is important. That starts on the day that they admit it. So we're going to be looking through all of their belongings, looking for dangerous objects, removing them and storing them for safety. We're also going to think outside the box when it comes to common objects that can be seen. I'm going to tell you, I've seen handle to brushes that come apart and things are stuffed down on the inside of them. When it comes to suicide attempts, individuals can become very creative when they are determined. So although it may look like something that they should have, if it can be used to cause them danger, cords to blinds, cords on phones, cords to appliances, everything that we use within the hospital, we just have to be cautious. bras can be used, sheets can be used. We have to make sure that we're providing a safe environment when assessing them for danger in their space, whether it be in for this particular purpose, it's the unit. So whether it be their bedroom, whether it be the day room, whether it be the nurse's station, making sure that we don't have anything on us, around us, or in the area that can be used lethally to end their life. And so, again, as I mentioned before, monitoring them in their room or doing a one-to-one is what we're going to need if we have a patient who's intent upon carrying out their plan. With a one-to-one observation, an individual is kept in constant visual with a staff member. So they are in that direct line of sight. I mean, it may even require that that individual be within arm length, especially if they've had a recent attempt, won't contract for safety, have no self-reflection or ability to have insight, or have poor impulse control. And then that individual, whoever that staff member is that's with that patient, will be documenting every 15 minutes that they've done something with the patient and that the patient is secure and safe. When it comes to our patients who have suicide, it's important to understand that our suicidal patients may begin to appear like they're feeling much better immediately before making an attempt to end their lives. So we want to make sure that we don't leave that person alone during this time period. In our minds, we want to think to ourselves, oh, they're feeling better. But majority of the time, they're feeling better because they're at peace, because they've made that decision and they finalized that plan. Another thing that we need to do is be making sure that if there are medications that they're on that require therapeutic levels, that we look at those. Because if we're giving them medication that should be helping them improve, but their blood levels are not saying that they're taking the medication, then they're storing that medication up. Allow for planning, look at consequences, and then come up with an implementation of plan for that individual. And I'm going to tell you, always include your patient. Other interventions that you can do is move the client to a room near the nurse's station, so that if for some reason you need assistance, if you're the one in constant visual with that patient, then when you cry out for help, everyone can respond. Give them a roommate, because a lot of times the roommates, a roommate who wants to live will not let anyone in their life. And so a lot of the times, again, we talk about that initial cry out for help. Well, they really want help. The first person they're going to tell, that trusting relationship they're going to have, is with their roommate. So they may tell their roommate, and in turn, their roommate will usually come and tell you. Always think about whether or not that patient needs to be a one-to-one, and evaluating and assessing the patient before suggesting or recommending that they no longer need a one-to-one. Look for medication hoarding and the cheeking of medications, and then frequently reinforce that contract with that patient. What if a patient asks you to keep a secret? Occasionally, sometimes a client may share with you his or her thoughts about suicidal ideations and request that you keep this confidential. This is usually a sign of ambivalence, that the client wants to escape the emotional pain of their depression, but they also want to live. So, what do? We have to remember that this is really a plea for help, and that they want to stay alive. So tell the client that you have an obligation. My obligation to you is to keep you safe, and that I can't keep your secrets if it entails your life being endangered. So some of the things that we might say is, I can't allow you to hurt yourself. We have to initiate and reinforce a safety contract. We have to reinforce the fact that we have to notify someone and then talk to the patient about what may have caused or triggered these emotions that they're having. Now, we said that with like any other mental illness, that there is no discrimination when it comes to age, sex, or any of that matter. So, adolescents, they're also at risk. And so, how do we help them? What predictors are we going to see of a depressed adolescent? Well, the risk is even more increased because at adolescents they also feel like their lives are, they feel like sometimes that they're invincible, but they're going through a lot of changes. Peer pressure to engage in substance abuse. If they've had a prior attempt to suicide, they're more at risk. If there's a family history of major depression, as we talked about in the lecture on depression, comes with having thoughts to want to harm themselves. If they are on, at one time or another, had to be on an antidepressant therapy treatment, then something may have flared up. If they have a history of legal problems or handgun use or handguns in the house, we also have to make consideration that there are other things that can exacerbate suicide in adolescents. And that includes the fact that they get this hormone induced anger. Their body is making all kinds of changes. And if they suffer from depression or anxiety, and then they have also the struggles of their own life on top of that, then that just compounds things. So we're looking at these things. Do they have this hormone-induced anger, depression? Is there drama in their life? Do they have issues with or making poor decisions or having poor impulse control? Are they risk takers? Do they have a crisis going on in their life? Do they have limited life experience? Are they using and abusing substances? These are all the things that we take into consideration when we are predicting the probability of an adolescent committing suicide. So how do we teach our patients? How do we teach them? What education are we going to do? Well, the first question is, how do you know when your client is ready to learn? That's the biggest thing when it comes to every mental illness that is taught in this course. And when you're answering questions, in the STEM question, is the patient in a position to learn? If they're in crisis, the thought that you're going to be like, let's sit down and let's discuss and consider what caused these triggers, it's not the appropriate time. So we have to do that. We have to make sure that the moment in which we're choosing to educate the patient is appropriate. On top of that, if the moment is appropriate, then we also need to look at whether or not the patient has a desire to want to learn. A lot of the times when the patient starts to talk about living, start making plans, acknowledging that they don't want to hurt the people around them and their loved ones. When they start talking about their the improvements that they have about themselves, that means going from a lower self-esteem to a higher self-esteem. If they say things like they see where they can make changes that would help, or if they can identify triggers or resources, expressing hope, and maybe just even state, I really don't want to die. But know that the crisis is over when the patient can contract for safety consistently over a period of time, that they deny suicidal ideations, and that they can express insight into those triggers and how to manage their depression. It's not just the patient, though, that we care for. Everything that we do requires that we care for not only the patient, but also the family. The family are also in bereavement, and to be honest, they go through this grieving stage in this suicidal attempt. And they also go through this grieving phase if the suicide is completed. Each suicide affects at least 6 other people, and that includes staff. If the patient commits suicide, we need to intervene with the survivors who may be at risk for suicide. Encourage them to support one another, but also to seek help. Remember what we said, that suicide can sometimes run in the family. So can this start a trend? A mother who says, this is my only son and I have no one else and I can't live without him? Or a father saying the same? Help them with their own feelings and with their responses. And then help them with counseling. Why do they need this? A lot of the times, victims of suicide are young children, teenagers, individuals who are intellectually impaired, the elderly. And sometimes it is individuals within their lives that may have caused them pain or guilt. Regardless of who these individuals are, the family needs counseling. It's a lot to have to deal with emotions. I get a little not apprehensive with lecturing on suicide, but you see it a lot. And over time, as nurses, whether you're in the ER, whether you're on med surg, it happens on any unit. And it's a very unfortunate circumstance, but it is definitely hard on family as well, especially if there's some history, good or bad. And so they need counseling. How do we help staff? Well, all nurses, not just psychiatric nurses, will experience suicide sometime in their career. It has a hard impact on staff, and so you have to encourage grieving for them to get that out. They need to process the event and then resolve any response to it. A lot of the times, it will be the first instinct to want to point blame, but it should never be a situation in which we're pointing blame. It is all about how do we prevent this from happening, especially on the psychiatric unit in the future. One experience that I have is a unit in which the patient was checked on regularly. And the patient went to take a shower, and they used a bra to end their life. And it was immediately, some of the staff thought that, who's responsible for this? Who did this? And that's not what you want to do. Whenever there's a loss like that, again, we're trying to prevent the completed suicide or acts of suicide or attempts from causing a trickle-down effect that causing other people to end their life as well. Because the rest that comes from that, it is possible. If as a staff member you have this guilty feeling that someone died on your watch because of something that you didn't do, that can have a lasting effect on individuals. So what our unit did was we stopped and we thought about it and was like, how was this able to happen? And it boiled down to, it had nothing to do with us, and more so to do with the fact that we had not updated the regulations on the doorknobs and hinges. So the unit went through and changed the hinges that was on doors and changed the knobs on doors, and actually, I think from that event we never had another one after that. But there's sometimes that's what it requires. Instead of blaming, looking at the situation and figuring out what you can do better. Was there any indicators that this person was going to engage in self-harm or suicide? Were they being appropriately monitored? Can the monitoring have been improved? And then it's going to be important to review and refamiliarize staff with safety procedures and policies. And this really sums up our suicide lecture for today.